Look at the brainstem nuclei. Several people are very astute and already picked out and said, well, you didn't really talk about it, but I can't decide whether the vestibular and cochlear nuclei are they in the medulla oblongata, are they in the pons? And truthfully, there's some overlap there. But this is the way you think of it. It's the cochlear, meaning hearing, is medulla oblongata. When you look at vestibular, that's the pons. Now the confusion comes with the fact that we haven't really discussed sensory and motor, and both cochlear and vestibular get motor neurons that come out of the pons. So there's some confusion there. So just to clear it up, and rather than go into a big talk about where we're never going to label, where a nuclei is in there. We're just knowing what should be there, and what it does. I'm going to leave it this: cochlear, medulla oblongata; vestibular, pons. We'll talk a little bit more about that special senses, but for now, that's it. Just separate it that way. And I agree with the couple that asked me. I'm like, maybe I should just spell that out more in the slides so you don't wind up having to ask. Then those are kind of things you don't ask. What happens when you don't ask something that doesn't look right on the slide? So, but somebody will still ask me that again. That's fine. I'm not awake either this morning, but I'm trying. Here we go. Brain, cranial nerves. Anybody try to learn them last night? I noticed y'all's endocrine drawing up here. That's awesome. Not really, but I like endocrine. I told them better than I do biochem. I'll take endocrine all day long because when I read through endocrine, I've had some questions that I actually think about with endocrine clinically when I was out practicing. Not a whole lot, but you got to look at it sometimes, and it helps to understand like the basics of FSA. But the class I don't like so much. But clinically, but I've never once sat in a clinical office and gone, let me do some biochem. Figure this patient out. So, I'm not putting down biochem, but that would be a lie. Right? I just put it. You need biochem to understand some of the things you're going to learn in here. Maybe not so much in clinic. It's the first block that you forget that you ever learned. And you understand something else because of that, but all you remember is what you understand that matters. If that made sense. Okay, naming cranial nerves. As you look at this drawing, this is the one. It's in your study pictures. This is the, 90% of the time I use study pictures. But when I'm asking you to label or identify any cranial nerve, it's going to be this picture, always. It's the clearest picture we have. I'm not going to black and white it, change it up. It's going to look just like that. I mean, if I asked you to identify cranial nerve 5 on a diagram, it would come from this picture. Simplifying that, because when you go out on the internet, there's 13 million different versions, right, of pictures of cranial nerves. And this picture is if you took the skull, not that you aren't smart enough to figure that out, but I'm supposed to teach, is when you look at, and you take this and we orientate it, right, it's looking like this. So when you say, and actually you can see the olfactory bulb and tract on here, cranial nerve 1, is you're going from anterior to posterior, but you're kind of going inferior as you go because it works its way down to the brainstem. So you think of this area as being very large, but we're talking a short distance. But that's how this is set up. So you can number them from 1 to 12 going in that order. Students are always breaking stuff. I tell my boss that all the time. They break everything. It's not me. And each one designates the name and it tells you its function. Now we say that in the beginning, but then look at them and realize if you've never studied them before, it doesn't make any sense. What do you mean it names its function? You got optic. Well, optic does, right? Abducens. That probably doesn't ring a bell until you start studying it. So you have olfactory, optic, ocular, motor. You have trochlear, trigeminal, abducens, facial, and if you drop down, that's where we get cranial nerve 8, can actually look for 5. This is the best way to orientate this picture, is to look for trigeminal, because it's the largest cranial nerve coming off of there. And then you have vestibulocochlear, glossopharyngeal, the all-important vagus, the accessory nerve, and then hypoglossal. So we're going to go into detail about what each one of these actually does. You don't need to highlight anything as we go along. I mean, you can. But for however many slides there are on these cranial nerves, so you got to know everything on it. I'm just being honest. You got to know cranial nerves. The only thing you don't need to know is when we get on each cranial nerve, at the end, there will be a picture, a demonstration of like how we test that. Because I like to talk about it so you've seen it, and then you'll learn to do that I think they do it this semester now, so that you see it and relate it to the cranial nerve. But I'm not going to ask you how to do it on the exam. We're not physical examining here. So when we get to those pictures, I'll tell you, I'll note them for you. So up front, I like to put some things like I would consider cliff notes for myself when I was studying cranial nerves. And they don't make as much sense to y'all because a lot of y'all haven't studied them in detail. And so it's listing characteristics and grouping cranial nerves to help you remember which ones do what. There are many ways to approach these. But one of the easiest ways, I think, is starting off this way and then going individually into each one, and then coming back and reading this and see if all that makes sense to you. So cranial nerves, when you look at them, either are sensory or motor or a mix. So we need to figure out which ones are sensory, which ones are motor, which ones are mixed. And then you have this statement. Those that are mixed may be primarily motor or primarily sensory. I'm going to say this a lot during this. And me and Dr. Sutherland would probably disagree. I'm pointing at him. Is to always tell him, who studied cranial nerves? Have you ever heard the acronym? Some people say Mary Money, and it's on the cranial nerve chart. Now you notice I built you a cranial nerve chart. Did y'all see that in there? I don't know if I've told this class yet. Any chart that I post up for a study guide, and I do that for cranial nerves, and I do that for musculoskeletal. I list the muscles and their actions and all that. I guarantee it's 100% correct. Meaning there'll be no discrepancy between my cranial nerve chart and these slides. If there is and you were to miss it, that's on me. I would have to give it back. I'm guaranteeing you that. If you don't like to build charts, use mine. But the reason I brought up the chart is I don't put that on. I've never studied, other than people try to make me, I never studied whether they're primarily motor, primarily sensory, because if you're learning everything about cranial nerves, we're going to learn every cranial nerve's function, whether that's sensory, motor. So I don't really care whether it's primarily motor in my mind, because it doesn't help me because I already know the cranial nerves, and you will too. So it doesn't make a lot of sense, but I will note it as we go along. You'll see what I mean. But I wouldn't learn that in acronym. Because I'll never ask you a question like, this cranial nerve is primarily motor. No, I'd rather ask you a question about its motor or sensory function. But I'm going to keep building on these generalities. I'll show you what I mean. So the first two cranial nerves, cranial nerve 1 and cranial nerve 2, are sensory only. They do not have a motor function. And the reason I spent so much time on the last slide talking about I don't care if they're mixed or primarily motor, primarily sensory, because cranial nerve 1, olfactory, cranial nerve 2 are, are optic, are sensory only. Every other cranial nerve is mixed, meaning cranial nerves 3 through 12 will have a sensory function and a motor function. Whether it has a larger motor function or a larger sensory function, who really cares if you know it has both? Right? That's my take. My wife, the PT, she's a physical therapist. She probably disagrees with me too, but she also hasn't practiced out there as a PA and stuff. They learn a bunch of funky things in physical therapy. I was a physical therapy assistant I know the funky things they learn. I'm like, do y'all really use that? Okay, one cranial nerve is so predominantly sensory that if you were to Google it right now, if anybody wants to do that, you'll see, if you were to Google what cranial nerves are sensory only, the internet, most of the internet will tell you, because they're generalizing some things, and they'll say 1, 2, and 8, vestibulocochlear. That's not true. And I just started off because of the question people asked me this morning. What did you probably don't remember, but I said motor neurons come from the pons and go back to the cochlear and vestibular areas, and they help set like their sensitivity. So there are motor fibers that are associated with cranial nerve 8. But most of the internet, even the video I'm going to show you at the end of this, will say that cranial nerve 8 is, because nobody cares about anything with cranial nerve 8 but its sensory function. But in anatomy, we know that it does. So the take home is only 1 and 2 are sensory only. I said most of that for the people who studied them before, because they studied it as 1, 2, and 8. If you've never heard it before, you don't need that. You just take my word for it. Right? When you look at motor cranial nerves, so there are no cranial nerves that are completely motor. We have 2 that are sensory only, but I told you the rest of them are mixed. So there are none that are exclusively motor. However, we do separate them and say, well, these are the motor nerves, these are sensory nerves, kind of based on the fact that if you look at cranial nerves 3, 4, 6, 11, and 12, they're the ones that have that predominantly motor function. But they're still mixed. Whether you want to learn that list or not, they're still mixed. If you have a nerve that has a high motor control, and you don't know what its sensory function might be, whether it's mentioned or not, it's going to be proprioception. But a lot of these tie into proprioceptive systems. So if you're looking at this general principle, the sensory function of nerves is proprioception of the muscles over which they exert control. So I don't always repeat that, but cranial nerves 5, 7, 9, and 10 are called mixed because they have equal amounts of sensory and motor. Once again, I know I talk about it certain ways. Are they still mixed? Yeah. So I give this class to sometimes to other people too, so and we get a little more into that. When you look at cranial nerves that have motor functions, generally they're going to innervate more than one muscle, except there are 2 cranial nerves that their sole function is to innervate one muscle, or motor. So trochlear and abducens. Trochlear innervates the superior oblique, which is a muscle of the extrinsic muscles of the eye, and so is lateral rectus. So the only job of the cranial nerve for trochlear and abducens is to innervate those particular muscles, superior oblique and lateral rectus. We don't have to mention the sensory side because it's going to be proprioception over that muscle. What is that muscle doing? Then the last one is something we're going to pick up along the way, is that there are 4 cranial nerves that have autonomic motor. So that's something different that we just threw in there. When we look at cranial nerves and we divide them up, I said there are cranial nerves that are sensory, and then you have ones that are mixed, sensory and motor. Well, out of those cranial nerves, those 4 cranial nerves, 4 of them additionally have autonomic motor axons. Because somatic motor axons go to skeletal muscle, autonomic motor axons go to the autonomic nervous system. So 4 cranial nerves up here. When you look at 3, 7, 9, and 10, all of these have autonomic motor axons. But they also have somatic motor axons. we know, I put it on the bottom, but the autonomic system controls things, autonomic glands, smooth muscle, cardiac muscle, that kind of stuff. All right, I love this dissection. I wish we had one. Found this in a book somewhere. Because somebody asked me like 2 years ago, no, they're not really yellow. But I feel like it's getting warmer in here. You don't feel it? Just me. Maybe I'm nervous. But that's an actual picture of a dissection. I wish we had it even in better detail to which they do on the internet or another, where they've gone in and kind of waxed up all these cranial nerves where you can see them as they lie in their places. So I just threw that back in there to give you a cool example. All right, cranial nerve 1, olfactory. It's 1 and 2 are sensory only, so the olfactory is sensory only. Olfaction means smell, so cranial nerve 1 conducts the sense of smell. I put a note there that says the olfactory bulb and the olfactory tract are not cranial nerve 1. Now, after saying that, I like to do word plays, but if I say that, well, let's do this because I don't use them. Before I leave, each cranial nerve we're talking about, I will have in red on their individual slide. Let's go back to this picture. The olfactory bulb and the olfactory tract are found there. But on this picture, if you were labeling that, what would you call that? Well, it is. But let me change the way I phrase that. If I was asking you to number cranial nerves, that would be cranial nerve 1, correct? But really, the olfactory nerves, as we'll see in special senses, are actually in your nasal epithelium, and you have bundles of axons that go up to the bulb and synapse in the bulb, and then go through the tract. We'll explain that in detail in special senses. So you have to say, well, the olfactory bulb and tract represented here are really not cranial nerve 1, but they needed a way to represent it on a diagram. That makes sense. It shouldn't be confusing. It'll make even more sense in special senses, but we're going to see the same thing with optic. There's some differences, but on a cranial nerve question, you would, yeah.
So, sir, what's representative is the bulb on the top and the tract is the skin part. And that's what we're saying is not the actual nerve.
Yes. And I may have put it in here. Yeah. Well, let's finish the slide and I'll show you that. I should have just I forgot I had some differences here. So the short function, you'll always see in each of my cranial nerve slides, I put the short function how to kind of help you. I'm going to give you multiple ways to try to remember this stuff on test day. One of the ways is short function. Smell. So you're looking for something to smell. Anosmia means you have a loss of the sense of smell. I forgot I had this here. This clear up what I said. This technically is the olfactory bulb, and the olfactory tract is behind it. If we come up here, this is the bulb, and then the tract's behind it. So we're blowing up this area here. Right, this is your nose, if you can't tell. These are your olfactory epithelium. And in special senses, we're going to discuss that there are bundles of axons that come up from the cells, the neurons that do the smell reception. Collectively, all of these, all of those going up through, this is the cribriform plate, which is part of your ethmoid bone up there. All of these bundles of nerves that are coming up through there are actually considered cranial nerve 1. But all I'm saying is that when we label cranial nerves and we say what cranial nerve number-wise is that, we still call it, that's cranial nerve 1. I'm pointing out a technicality. Spending too much time on it too. I think most of y'all get it. So if you want to test olfaction, you can take something, a smell. It has to be something that's readily identifiable, right, or offensive. actually not offensive. But in PA school, we always had little film canisters. You ever seen a 35 millimeter? I have to ask nowadays, 35 millimeter film canister. We use those. We have them in our little kits. And you never knew while we were practicing, even sometimes during testing, because you're going to close your eyes and they're going to have you close and smell, and you're supposed to tell them what it is. You generally have two different smells. And you're like, oh, that's coffee, whatever, because it's recognizable. And now we know that they can smell. But you never knew what was going to be in that when I was here. There was some nasty smells coming when we were there. So I am encouraging that for fun, but I didn't say that. You got to edit that out, please. I give a lot of exam advice. The fact is, how many people have read a chart and see that anytime you see cranial nerves annotated, it says cranial nerves 2 through 12 grossly intact. They don't say, why don't they put 1 on there? Because first off, they didn't test it. And the reason they didn't test it, and you won't test it, if somebody can't smell, they're going to tell you they can't smell. You don't need to really test it. You know, like legal-wise, should you test it? Probably, yeah. I've never seen anybody test smell other than having kids try to breathe in and out with peas in their nose. They're really not. Nobody's carrying around a damn thing of coffee with them in a canister going to smell that. That's why it says, and what does grossly intact mean? It means I got a busy day and I didn't really look, and they're 25-year-old military. They probably don't have a cranial nerve problem. Anyway, you'll learn what I mean. It's like putting, you know, what does it mean when you put WNL on a chart? Yeah, we never looked. We never looked. What I love nowadays, trying not to digress, but I love nowadays, you go to the clinic, and I gripe about medical stuff all the time. I can't stand it. I will go back home, when they post their note into Genesis, I will read it. And always nowadays, there is stuff on there they did not look at, they did not ask, they put it on there after the fact, and that's just wrong. If you I'm not going to get on my soapbox, because you should document exactly what you do, even if you failed to do what you were supposed to do. Well, what's the best way to remedy that they should have done if they went, oh my gosh, when I evaluate them for this, it's mandatory I ask this, being generic. I should have asked that. I need to know that. You can't just put it wasn't there. You got to pick up that phone and call that patient and say, hey, I forgot to ask you this. But they don't. They just go read your charts if you don't believe it. They got stuff in there they never talk to you about. They have stuff from other patients in it. Nowadays, y'all are going to be, I'm not going to digress about this. You know that slide. But, I went into a clinic, and it was a pediatric clinic, and they had microphones and cameras in every room. And when that provider goes into that room and starts talking, they have an AI software or something in there that it filters out anything not related medically with the patient and sorts that all out and writes the note. So as they're talking, it's writing the note for them and only putting the pertinent medical stuff in there. And then they just have to review it and make sure it was right. I could have seen like 100 patients a day. That's why I don't want to do clinic anymore, because you got to write so many damn notes. The bean counter is making you check off too many things. You got any bean counters? No, I'm going to stop. I don't want to offend everybody on the first one. MSC officers, bean counters. Not so much nowadays. Before they started adding MSC officers to like platoons and stuff, I just called them bean counters. They were in the hospitals and clinics, and all they would ever tell me is, hey, we're going to need you to see more patients each hour. Why? I'm doing good. Okay, sorry, I got way off. Let me draw us all back. Optic. We're on to optic. We did oculomotor. Cranial nerve 2 is the optic nerve. The short function is vision. Vision. Because cranial nerve 3 controls muscles of the eye. Moving the muscles of the eye has nothing to do with vision. It has to do with tracking and things. We're talking the retina, the visual pathway, is controlled by optic nerves. So they conduct nerve impulses for vision. There is a difference, once again, the optic nerve versus the optic tract, the optic chiasm. So I have to draw on here again. A lot, you're going to notice I reference special senses a lot, because most of the functions that we're talking about with these cranial nerves ties directly into a lot of the special senses, which is neck, is test 4 stuff. But when you look at, it's in red there, but I'm going to put some eyeballs out here. Let's say we had some eyes. I know that's kind of hard to see. There's some eyeballs, and then we're going to have, I'll change colors. And then we're going to have an optic nerve that comes out of the back of each eye and goes to this area, right at the pituitary, and you're going to have some axons from one eye, left eye, right eye, and they actually, some of the axons from each eye cross over, and that's called the optic chiasm. And so once it crosses over, and you don't need to know this for this test necessarily, that's because we'll get to this, but I'm going to draw this really long, just for reference. This would be called the optic nerve, because you could label that and say, well, that is the right optic nerve. Remember, it's upside down, flipped towards us. So that's the right optic nerve. And we would call this the right optic tract. Reason being is the right optic nerve only contains axons from the right eye. But once you go through the optic chiasm, the cross, you're going to have fibers in the right optic tract from the left and the right eye. I'll explain that more in special senses, but for now, that red thing on there is cranial nerve 2. So, optic nerve talks about vision. When we talk about vision, we look at the retina. The retina is where we have rods and cones that are associated with perception of color, or the sensation of not just color, sight. Sorry, be gray, black, white, right? Color. And then they're going to have bipolar cells, because bipolar cells are only associated with certain special senses. And this is one of the areas we find bipolar cells, and the bipolar cells are going to convey the info from those rods and cones to a ganglion cell, and then a ganglion cell is parted down here in the retina, and all of these fibers will lead together and become the optic nerve. It will become the optic nerve that goes into the back of the eyeball, or comes from the back of the eyeball. So for now, that's it. We'll talk more about the crossing over and what goes on. It's kind of interesting when you talk about visual fields and stuff, but we don't need to get too far ahead. But that's what that pathway looks like. If you want to test this, that's where they normally test your peripheral vision. Rather than stick them in front of a Snellen chart or do some computerized testing, you can just test peripheral vision. You're comparing it yourself to them. Right? You're covering the same eye. You see that yet? Doing all these crazy things. That's how you test it. So remember, a quick cranial nerve exam is just a basic exam. Because most people, you're not going to find problems with their cranial nerve. All right, cranial nerve 3 is ocular motor. Ocular meaning eye, motor meaning moving the eye. So cranial nerve 3 short function is eye movement, not eye vision, eye movement. So it controls, there are actually, and I'm not going to discuss the other 4, there are 6 muscles, extrinsic muscle. Y'all know the difference when I say an extrinsic muscle to the eye versus an intrinsic muscle? I always say that, and you know I'm going to say what it is. An extrinsic muscle of the eye would be outside of the eyeball attached to it and moving it around. An intrinsic muscle to the eye would be like this ciliary muscle and constricting your pupil. So anytime you hear intrinsic, extrinsic, intrinsic, inside. So there are muscles inside the eye, there are muscles outside the eye. Oculomotor controls 4 of the 6 extrinsic eye muscles. The other 2 are controlled by trochlear, right, and abducens. We discussed that in the beginning, but so 4 of them are controlled by cranial nerve 3, except for 4 and 6. And this is where it starts to get, we're going to start adding. The rest of the cranial nerves aren't as easy as 1 and 2. 3 starts to add in and say, okay, well, what is, now we have innervates the intrinsic muscles of the eye. You're like, well, wait, we just said that cranial nerve 3 innervates the extrinsic muscles of the eye. That's true. This is where you got to start getting your mind around it. You remember in the beginning I said that all 3 through 12 are mixed, sensory and motor. 1 and 2 are sensory only. We're to 3, so we know it's mixed. So we know it has a sensory function and a motor. The motor function for cranial nerve 3 is eye movement, extrinsic eye muscles. Sensory function, basically proprioception of those muscles. Intrinsic movement, I just said they're intrinsic muscles in the eye. That means that cranial nerve 3 is one of those 4 that has a autonomic function. Or there's 4 of them. So this is one of them that has an autonomic function. So you get this busy picture. Do not start labeling and learning all the different extrinsic muscles of the eye. I only want you to pick up the ones that I'm talking about on the slides for now. So you have parasympathetic. I failed to mention that earlier, is 4 cranial nerves have autonomic functions, motor functions, but it's always going to be parasympathetic. Now I feel like I need to explain why I said that. It's always parasympathetic. We're going to discuss in detail those systems, but the parasympathetic system is called that because when you look at the thoracic region, to generalize, that's going to be sympathetic output. But when we look at the sacral and the cranial, cervical region, that is parasympathetic output out of the spine. So it's para. It's on both sides of the sympathetic output. So a lot of our cranial outflow of the parasympathetic system is the cranial nerves. Does that help clarify why I was saying that? That's why it's called the parasympathetic system. So you won't have sympathetic fibers coming out of these cranial nerves. And it also innervates, yes?
So the intrinsic and extrinsic are both parasympathetic?
No. He said the intrinsic and extrinsic are both parasympathetic. Only thing that's parasympathetic is the intrinsic. The extrinsic eye muscles. And you can relate that. You can look around the room, right? We can do crazy things with our eyes. We can move them. But do your pupils adjust on their own? Yes. Nobody's sitting here going, think I will decide to dilate my pupils right now. No, that's an autonomic function. Think about those silly things that I say when you're, and if you hear it, that's not necessarily true, so I won't say it. Intrinsic versus extrinsic. All right, when you look at levator palpebrae superioris, that is a muscle that is innervated by ocular motor. When we study the eye in detail and its actual movement and the muscles of facial expression, we're going to see that this muscle is kind of special. If you don't know muscle names yet, you got to start learning how to break these things down. It'll help you greatly. I do it a lot in musculoskeletal, but I always write. I don't now because I know. What's another way you could write levator palpebrae superioris? How about the upper eyelid elevator? Right? Because you read the words and they all start to run together when they sound funny like that. But it's just saying it's the upper elevator of the eyelid. And this muscle functions kind of independently. It's what you're using when you're in your absence seizure. Right? You're out, but your eyes open. Because when you're in your absence seizure, you have no other facial muscles that I can see working. You know, facial muscles allow you to smile and puff out your cheeks and all that. But when you're in absence seizure, you have no facial expression, but your eyes are still open. Right? So, that'll be funnier in special senses. If you want to test ocular motor, that's that pupillary light reflection. Right? When you shine a light in one eye, both eyes should constrict. And anytime you shine a light in the pupil, it's going to constrict to try to decrease the amount of light coming into there, and it should be consensual, meaning both sides should constrict. Once again, if you want to, in your study stuff, if you like to delete these test slides out, you can. I'm not going to ask you how to test it. Trochlear, cranial nerve 4, innervates the superior oblique muscle of the eye. It's the only thing it does. So it's eye movement. It's also the only cranial nerve to rise from the posterior aspect of the brainstem. Great. If you're ever on Jeopardy, you can use that. I don't know why I leave that in there. Yeah, dude, because if you go and talk to like physical therapists or people that are spending a lot more time on this, they actually look at a lot of times where each cranial nerve is coming off of the brainstem and to find that out. I don't spend as much time on it in here. So that's all. That's it. Cranial nerve 4 is innervating superior oblique. What we don't know yet is the reason it's called. Remember at the beginning we said the name tells you its function. They named cranial nerve 4 trochlear because it innervates superior oblique, and superior oblique, in reference to the extrinsic eye muscles, goes through a trochlea. I'm going to switch my colors back. So this is a trochlea that we find up here. And if we were to, later we'll trace these out, but superior oblique actually comes up, goes through the trochlea, and then comes back here and attaches to the eyeball. And it's going to change the way you would expect that muscle to function. For now, the superior oblique moves the eyeball inferiorly and laterally. That's inferior lateral. Or what in eye ophthalmology you would call that to the down and out quadrant. But inferior and lateral. I think it's getting warmer. And you're going to be sweating, but at least you're in PT. Am I going to laugh today? Like A&P too? Oh. It's nice that they let you. Let me finish the slide. If you want to test the extrinsic eye muscles, specifically for here, cranial nerve 4 only innervates superior oblique. But we test the extrinsic eye muscles all by using the same exam. We'll discuss later that, unlike I thought when I was a medic in the 25th Infantry Division of Hawaii in my first tour, I did a lot of those. Whenever they'd send us over and we'd get a chance to go in the clinic, and they'd have you test people. You know, just do it anyway, whether they're there for that or not. And you know, and they're all over. Yeah, follow that. I don't have a picture. Follow that. There's a reason why you watch somebody do an eye exam. Have y'all started doing this in clinic? Oh, okay. You already know this. Right? We're isolating muscles so that we can figure out which muscles, because every movement of your eye generally involves more than one muscle. Right? Y'all are going to hate this section of special senses because I get into this, but when you want, if more than one muscle is used, how do you know which muscle or nerve has a problem if you don't isolate it? And so the eye exam actually is a way that we can isolate muscles for now. I think it's interesting. You won't find it as interesting. It's one of those areas where we'll probably slow down and be there for 20 minutes on 2 slides figuring that out. Because I don't like to leave class that day without figuring it out. Because if you get home by yourself and you're like, what is this? I was going to say before we start trigeminal that y'all have it lucky that you can just wear PTs all day long. Don't mess that up. We had, when I was here, we were across the way, I think, where the sophomores are, but we only had half the room. But we just lived in that room. Right? We walked around here with a 1,000-yard stare. Nobody messed with us. But if you left this floor for any reason, you must be in VDUs. You must be in your VDUs. So if you wanted to go down to the shop ed, you would change, go down to the shop ed, come back. Crazy. Crazy. So we would change multiple times a day. You got, after a month or two of that, nobody's worrying about going to the bathroom. There's people changing every time you walk in the room. It's just a free-for-all. Not in that regard. In changing, like nobody cared. Like they were all deployed. All right, trigeminal. Trigeminal is the largest cranial nerve, and it is very, very busy. We're going to see that trigeminal and facial are both very busy cranial nerves. The trigeminal nerve emerged from the pons. It's kind of isolated from others. So that gives us a reference point. So here's the pons. And then in red on each side, the larger areas, that tells you it's kind of high. So when you're numbering them, you can go 1, 2, 3, you can't see 4 very well, 4, and then 5. So that's how we can pick up our numbering. Okay, provide sensory to the face, the head. If you look at an individual and you're discussing dermatomes, sensory, we haven't discussed dermatomes, but dermatomes is sensory maculatus. You always need to picture there's a Roman numeral 5 on their face, a V. And that tells you that cranial nerve 5 controls sensory of the face. When you look at its additional actions, though, it also does the anterior 2/3 of the tongue. So trigeminal provides sensory fibers from the anterior 2/3 of the tongue. It also has motor neurons that control mastication, which is chewing. Mastication means to chew. So those motor neurons out of this cranial nerve will help that. And so the way it's divided up is you have a smaller motor root that is going to the muscles of mastication. Doesn't matter what the muscles are yet. It's helping you to chew. And then you have a larger sensory root that is providing 3 branches. And it's going out to an ophthalmic branch. Guess where that's going? The eye. A maxillary branch. Guess where that's going? Maxilla. And then you have a mandibular nerve that is essentially going to the lower jaw, which is our mandible. Goes up by the ear too. But that's what trigeminal is doing. If we divide this up, I'm convinced that PowerPoint screws with this slide every time. Because every semester I go in here and block this out. I must not be saving it right. Does yours show all these things in here? Are those there? I don't want you to do that. You'll notice on almost every other one of them I have, these are gone. These are gone. I'm only using this to show you that there are 3 branches of cranial nerve 5, and that we call them V1, which would be the ophthalmic nerve, V2, which would be the maxillary nerve, and then V3, which is the mandibular nerve. And all I really want to reference here, not all those little sub-branches there, right? That purple area is your ophthalmic region, there's your maxillary region, and then you have your mandibular region. So it's providing the sensation for those areas. And that's how we would break that down. Don't learn all those little branches. You also have, coming off of the maxillary nerve, right, B2, maxillary nerve is where we actually can do local anesthetic like a dentist does. So here's your maxillary nerve up here, branch. And it's going out and branching down. And so you can actually go into the mouth up there and put an injection in there and you can anesthetize probably that half of the maxilla. When y'all do it on each other here, right, I think they go for the inferior alveolar nerve, which is going to get your mandible. Got any dental techs here? I'm pretty sure I'm right. It's down there. We'll talk about it. Is that the first time y'all heard you'll do dental anesthesia on each other? Have fun with that. I was numb for like 8 hours. We had 29 of us. We were all doing it at the same time, paired up. So that's an odd number. I have to follow up. How many computers is that? Either way, there was one person in there, and they were walking around, and it was this old crusty guy, and he was walking around, and I'm laying in the chair, and they got the needle in the cheek area there. He walks in and goes, no, more this way, and grabs it. When he did that, it tinged that nerve. It hit like the nerve and just sent electricity down my jaw. And he had given us like a short act. It should have lasted like 2 hours. And I was like done with dinner later that night, 8 o'clock. It was still numb. Never saw him again. All right, the assessment of motor function for cranial nerve 5, trigeminal. Out of all those things that it does, we generally, they'll just have you clench down. You can either have them attempt to open their mouth, because opening your mouth is part of mastication. So you see people say, okay, open your mouth. You're just kind of feeling that there's pressure there. Same thing, or you can put your hands on where the buccinator muscle is and have them clench down. And your jaw should pop up, right, the muscle there. That's how they'll test it. Another way you can test it, because of all its functions, is you can have the patient close their eyes, and you can do sharp dull, or you can use a cotton whisk. You're just looking for general sensation. We're not really have to get into sharp dull just yet. You have them close their eyes, and if I was to touch their forehead, they can't feel it. I know they got a problem with the ophthalmic branch versus the mandibular, right? But we could do that real quick. Another way is like when you go to the eye doctor, they do a glaucoma test. You can also kind of use that where they do a corneal reflex. They're talking when they blow that air in your eye, that's going to do a corneal reflex. But you also could take like it's the thing, it's Q-tip, like a hospital one, and I've pulled the end out before, and you can just you touch the eye with it, and it'll give you that corneal reflex. A lot of different things. And I put another reminder that cranial nerve 5 is the dermatome of the face and scalp. We'll start cranial nerve 6 after the break. Yeah, it's definitely getting hotter.
I need there. If you numb me up for 8 hours. Stick your tongue. Yeah, just like you're trying to get back there. Do you make it?
That's the way.
Yeah? Yeah.
to really, we can use the skull, the whole skull. Down and out. Superior oblique actually comes up above the eye, and then comes back to your hand. If I pull on it, that makes sense. We're going to do that. Goes up, loops, back, forward. It's one of the more Is that how you're at? I'm trying to figure it out. Don't focus on them. They're all mixed, except one. You are, I got it. I got it. Yeah, that makes sense. The elbow is going down like this, right? So this is more high. Inferior. Oh, yeah. Like this is going to go. See what I'm saying? So, it's going to go. It's like this. Down. So if I up, just had to talk it out. I was sitting there staring at it and I was like, this doesn't make sense.
Grab it out.
It's just that. Yeah, that's kind of cool.
No, like, all the projects that's good.
That's what I'm going to help you over and over and over.
just write it down. Because I fucking memorize. No, that's correct. Yeah, he's just saying that in some places, he said in some places, there's some, we're talking like, that's not true. In general, that's what I stay with that. All the time, I was happy to I really don't.
I can't walk down the road, I'll get started talking, I'll be late starting.
Did you say that?
The thing is going to be
Learning?
it's a question of which one is the comfort?
Okay.
That's the one in the middle.
I went and like just grabbed it and then I looked at the back.
570?
570, 35 grams of sugar. Oh, that is a power bomb. What do we got here?
That's gonna make you prep this shit so bad.
Yeah, I know. I know. So much sugar. God.
Yeah, there you go.
10 grams of fat. So there's 90. So 27 times 9 is what? 180. It's like 200 calories right there. Probably should take this like closer to right. Yeah. Just as we run out.
Alright, so, questions I had to break.
2 in.
One of the first ones was, and it's a great question. Y'all ask good questions. This class always does. And I'm one of those people that, like when I start learning something, I have problems understanding it sometimes if you don't tell me how. No, I'll get stuck on it. How? And the how comes up with looking at, I'm just going to say this for reference. I don't want y'all to go here just yet. When I pulled this up and I showed you, I'm being very general on the extrinsic eye muscles. Apparently I can see some faces. More y'all have questions. Is you look at it and say, well, trochlear innervates superior oblique. For this test, all that I care that you know about the extrinsic eye muscles is what cranial nerve innervates them, right? Meaning, and if there's a named muscle, you got to know that. So if you look at ocular motor, it innervates 4 extrinsic eye muscles. I didn't give you their names. There's a picture that has their names. I don't want you to know their names just yet. We're going to get to that. And so I did give you superior oblique and abducens. because when you look at cranial nerve 4 and 6, you just have to skip them if you didn't do that. But that's all they do is innervate that muscle. So for this test, the answer is always the superior oblique moves the eyeball inferiorly and laterally, which is called down and out. Moves it this way. We're going to spend a lot of time on extrinsic eye muscles and how to do it, how it affects it when you do a physical exam and all that, and special senses. For now, the question was, I'm rephrasing the question. How in the hell does the superior oblique muscle, which is up top, cause it to go inferior and laterally? Shouldn't it bring the eye up? I don't want you. If you don't need to hear this, shut your ears, because this is going. I don't want you to know the how yet, but because some people need it, including me sometimes, superior oblique is actually coming from behind the eye, and it's going up through a trochlea, and then it's attaching to the top of the eye. So when I can't even describe it, it's going up and back, and so when you pull it, it's using that trochlea to turn it down. That's just for the ones who want to know that at this point. For now, what does superior oblique do? Moves the eye inferior and lateral. I'm trying to say that so when you're getting home and you're studying this next week or whenever it is, you have that thought in your head, or you hear it again on there if you listen to those things.
So there was multiple questions?
Of that, yeah, probably 5 or 6.
On that same exact
No. Is that what you were asking? I'm kidding.
You said there's multiple questions during the break, so I didn't know that was perfect.
Oh, yeah. So what was the other one? What'd you ask me?
Oh, cranial nerve 0.
Oh no, that wasn't the question. That wasn't it. Oh, somebody asked me again about, hey, cranial nerve 3 on your chart has an M for motor, but in parentheses it has a B for bow. Let's just make it as clear as I can be, even more. And it's not a bad question because you've got to know every little detail. I'm going to restate this. I expect you to know that cranial nerves 1 and 2 are sensory only. I expect you to know that cranial nerves 3 through 12 are mixed. I don't care whether it has more motor or more sensory. And the reason for that is, if I ask you a question, it's going to be, what is the motor function of cranial nerve 7? Right? What is the sensory function? So you already got to know in detail in this class. If you want to learn that it's primarily motor to help you remember out in clinic, you can do that. But I'm not going to ask you whether it has more motor or more sensory, because all of them but 1 or 2 have both. Y'all getting me? Don't learn that mnemonic. It's the one that some people say, and I know what you're thinking. Some of you are like, well, why don't you take it off your chart? Well, depends on who you teach it to, but I probably should for y'all. We don't need it. I'm going to go argue that again with Dr. Stevens this afternoon, just for fun. Actually, I don't argue, I discuss. People call discussing things nowadays arguing. You notice that? If you don't agree with somebody, you're arguing. I mean, you're wrong. How is that arguing? I'm stating a fact. No. So we already covered that. We're on cranial nerve 6. Okay, cranial nerve 6 is abducens. The only job of cranial nerve 6 has motor fibers that go to the lateral rectus muscle of the eye. Lateral rectus muscle, guess what? It moves you laterally. Your eye is out, not you. Your eye laterally on each side. And we're talking both eyes. So if we just look at the right eye, you have a muscle, a lateral rectus, and it allows you to, what would we call anything that moves away from midline? Abduction, abduction, adduction. So if your eye moves laterally, that is abduction. That's what the name of the nerve is. Abducens. That's why. Because it abducts the eye. That makes cranial nerve 6 one of the easier ones, because that's it. This is a good example. This picture, and I don't remember it, may be in your study kits, but if it is, The only thing I'm using this picture for at this point is to say there's 3 branches. I don't want you to come out here and label lateral rectus and superior oblique and all that. I don't want you to label those muscles yet on that, okay? Write that there if you're one of those people that does that to every picture. I'll expect that next test. Okay, so we use 3, 4, and 6. We can all test with doing the eye exam. We're going to move on to facial. Facial, you're going to confuse with trigeminal. If you're going to confuse anything, you're going to confuse. There's a difference between just not knowing and confusing it because they have some similarities in the way we discuss them. But cranial nerve 7 is facial. It has a lot of somatic motor axons that innervate mainly the muscles of facial expression. And then it goes on to innervate stylohyoid, posterior belly of the digastric, stapedius muscles. I got to kind of describe before we get there. The stapedius muscles are small muscles in the inner ear. This is a muscle that's down under the tongue. Stylohyoid is part of our neck muscles. Generalities here. But most of what we discuss with this in the cranial nerve part of it is facial expression. So everything that Jim Carrey can do with his face, he's using cranial nerve 7 to do that. This is the second one. Because remember, cranial nerve 3 had autonomic output, parasympathetic output. So does cranial nerve 7. That's the second one of the 4. In this case, the axons for the parasympathetic fibers go to the lacrimal glands, the nasal glands, saliva, sublingual, submandibular. What do they all have in common? Is if you stimulate cranial nerve 7, you're going to start to tear up and have mucus and mouth watering, because they're all the same. They're all coming from the same cranial nerve. And this is where we get our first confusion. Cranial nerve 7, the facial, has sensory axons that extend from the taste buds in the anterior 2/3 of the tongue. So when we look at differences, facial has taste buds from the anterior 2/3 of the tongue. Let's back up and see if we've seen anything like that before. Cranial nerve 5 provides sensory neurons to the anterior 2/3 of the tongue. What's the difference? Anybody pick up what's the difference?
Yes.
Thank you. Yes. Cranial nerve 5 allows you, is sensory, a big V on the face, and it gives you sensory, which a better word for that is tactile, like touch. So if something touches your tongue, cranial nerve 5 is responsible for carrying that information to the central nervous system. If you're tasting, taste is a special sense. Right? So if you're going back to cranial nerve 7, it has fibers that go from the taste buds on the anterior 2/3 of the tongue. That's anybody that can't kind of see that, because that's what's going to get you. That's the one everybody confuses. Yeah.
So if you drink hot coffee, that's going to be 5. Like
Yes.
on your tongue. Because
Yeah.
you're going to feel the sensory. You're going to taste the coffee with 7.
Yeah. It's a good way to put it. He said, so if you were to drink hot coffee, you would burn yourself, and cranial nerve 5 would pick that up. But you would still taste the coffee, and that would be cranial nerve 7. Yes, exactly. Somebody's still going to confuse it. Draw it out. Draw it out, and always remember, anytime from here and in special senses and any other class that talks about like special senses versus general senses, when you say general senses, tactile senses, we're talking touch and all that. But always keep that key in your mind. When you see something about a sensory function, go, wait, is this a general sensory or a special? And that'll help you separate those out. All right. One of the other reasons that facial gets confused is because it actually has branches also, except for it has 5 branches. Now, I like math. And so we call it trigeminal, and it has 3 branches because it's tri, and I get that. But what's the cranial nerve number for trigeminal? 5. Then we come to 7, and it's the other cranial nerve that has branches. The cranial nerve 7 has 5 branches, so it kind of messes with the math in my head when I was first learning these, because I would confuse them, like, which one has 5 branches? You know, and then I had to reflect back and go, okay, well, it's called trigeminal. You know, I know it sounds funny, but I'm telling you things that I did when I was learning. But here are your branches. They are named for where they're at. You have the temporal branch. You have the excuse me. You have the zygomatic branch. If you don't know your high cheeks, your zygomatic arch. That's the zygomatic branch. You have the buccal branch, which is your cheeks. And then you have the mandibular branch, which is your jaw, your lower mandible. And then you have your neck, cervical. They're all named for where they're at. And if you realize that another confusing factor is that trigeminal, cranial nerve 5 and cranial nerve 7 both have a mandibular branch. We could say one of them is called marginal mandibular to help simplify that, but they both have a mandibular branch. So if you want to test it, that's where they tell you, hey, smile. You do all those silly things in the clinic. Smile, puff out your cheeks, raise your eyebrows. All of that is assessment for facial muscle function. Cranial nerve 8 is vestibulocochlear. We've heard of that many times already. It used to, when I first learned them, it was called the auditory nerve or the acoustic nerve. It has branches. It has a vestibular branch and a cochlear branch. Made me think of something from last semester. Nerves start as large nerves, and then they get down to an area. I'm going to say this now, and hopefully I'll say it again. If we picture a nerve coming down our arm, it's going to provide motor innervation to some things, and then it may provide further motor, but it's also going to have branches that come off and do some sensory functions too. Right? So we recognize that nerves have branches. This is what the last class a couple people didn't understand. I want to clear it up now, because I thought of it. So we know nerves have branches. That branch then can be called a nerve. Does that make sense? By definition of a nerve. So I use that interchangeably like everybody else does, but if you're new to this, you wouldn't think that. And it's things like the vagus nerve. Vagus nerve has a branch that comes back up to the larynx, right? It's called the recurrent laryngeal nerve. But when you're discussing vagus, you would say the vagus nerve has a recurrent laryngeal branch. But when you're discussing the pharynx, you say, well, it's innervated by the recurrent laryngeal nerve. So the branch of that nerve can still be called a nerve. It came up, they asked, it was on a question, of course, and they're like, they didn't realize that saying branch and nerve were interchangeable. All y'all must be, y'all are the smarter class than all of them, because all y'all are looking at me like, you didn't know that? Come on. Anyway, I try to bring things up. It's kind of out of place to say it there, but I was doing that because when we look at this, you have vestibular and cochlear branch. Vestibular and equilibrium words always go together. Cochlear always goes with hearing. So vestibular is really referencing how we keep our balance. So it's balance and hearing. When we look at the vestibular cochlear nerve, we're going to learn in special senses that you have some areas called the semicircular canals, or semicircular ducts there, and then you have the cochlea. Cochlea is hearing, semicircular canals areas are for balance. They're like a gyroscope. I'm going to leave it at that for now. We're just separating vestibular and cochlear. One of the easy ways to test this is you take your fingers and you're rubbing them together, you put it very close to the ears, and you just ask, does that sound the same? Kind of subjective, but that's what we do. one doesn't sound the same, then maybe you would do something further to test their hearing. All right, glossopharyngeal, cranial nerve 9. Always, if you're new to them, break them down. Because some people, I would assume everybody in the room knows when I say glosso, what that means, but I know that I'm wrong. I'm not putting people down. You learn that. You go to an engineering class, I wouldn't know their shortcomings either. Shortcomings. Did you have a question?
Earlier you said that if you Googled 1, 2, and 1, 2, and 8 would come up as sensory only. You said 8 as motor. Where's the motor?
It is helping to set the sensitivity, sending signals back to set the sensitivity of those receptors. There's a motor function that goes back to it. Nobody likes to mention that because it all talks about hearing. Now, when we look at, we'll look at that more in special senses. I just don't want to get into it. When we look at glossopharyngeal, you ever heard of glossitis? Glossitis, inflammation, infection of the tongue. When you say glosso, you're talking about the tongue. Pharyngeal, so something to do with the tongue and the pharynx area. So glossopharyngeal will provide sensory axons. This is going to throw you for a loop for some of y'all. To the posterior 1/3 of the tongue for taste and taste buds. For glossopharyngeal, does tactile, sensory, and taste buds to the posterior 1/3 of the tongue. Somebody was really messing with this when they set these up. Right? So it does both. The facial and trigeminal do separate. It also goes to baroreceptors like in the carotid bodies or arteries or sinus, chemoreceptors in the carotid bodies. And this is our third one that has parasympathetic motor axons to the parotid gland. That's all it goes to. Controls release of fluids from the parotid gland. So taste, salivation, innervates the pharynx. That's its short function. So here is glossopharyngeal, kind of showing you the extent where it's going out here to the parotid gland. It's coming down to the chemoreceptors, things. It's also receiving taste and touch from the backside, posterior 1/3 of the tongue. Okay, so having the patient open their mouth and say ah when they stick out their tongue, you're observing because it innervates these areas of the pharynx. The uvula, the soft palate, when you say ah, should rise, and the uvula punching bag in the middle of the uvula should stay in the middle. Right? We're also listening for hoarseness when they do that. That's why we say ah. You should open your mouth and say ah. If you hear ah, that's hoarseness. Now, I'm just going to flatly say this because I've asked it many times before, but this is how you assess cranial nerves 9 and 10. Cranial nerve 9, glossopharyngeal, is what's causing the soft palate to rise. Somatic motor voice production is controlled by cranial nerve 10, vagus. But you test them in a basic way the same way by doing this test. Stick out your tongue and say ah. But I've asked this before. I say, well, what's responsible for voice production? And people have answered cranial nerve 9, and the reasoning is they come in, and I want people to stop making this mistake, and they'll come in and say, well, I looked at this picture, which I told y'all you could X out if you want. I looked at this picture, and it shows the guy with the tongue sticking out, and it says 9 and 10. And I'm always like, yeah, but I explained that to class. So this go around, if you miss that, if I ask it, we're going to pull the video up. I'm not trying to be ugly. I say it all the time. Cranial nerve 9 rises the palate. Cranial nerve 10 does somatic motor voice production. Just throwing that out to you. Don't miss that effect. Shooting for 100% effect. Trying to drive that home. And we get to the busiest cranial nerve. Everything happens in vagus. Everything does. Longest cranial nerve. If you look at it, there shouldn't even be a short function. It should be long functions. swallowing, talking, cardiac, GI, respiratory, and taste. That's really simplifying because the vagus goes everywhere. Vagus is going to be the fourth one of our cranial nerves that has parasympathetic output to about everywhere. It's widely distributed throughout the head, neck, thorax, the abdomen. Like I said, it's easier to talk about where vagus doesn't actually reach instead of looking at where it does, because it goes everywhere. So here are all your functions. The somatic motor function, autonomic motor function, and sensory. Sensory for the vagus nerve functions taste, touch, pain, temperature, proprioception, all dealing with the area of the epiglottis and the pharynx, monitoring blood pressures, oxygen, carbon dioxide. So you would say that taste, once you get past the posterior third of the tongue, that glossopharyngeal was picking up sensation and taste. You get behind that into your oropharynx, that's the job of cranial nerve 10. You do have a few taste buds back there. Right? And it's not, and you get it if you've ever been to Vegas, depends on who you are, I guess. You go to Vegas, you wake up in the morning and you have that aftertaste. Right, you get Vegas, cranial nerve 10, it's already past your tongue, you got that aftertaste in the back of your mouth. I've never done that. Sure you have. That's a whole different thing. I'm not bringing up. Somatic motor function used in swallowing. Later you're going to learn that swallowing involves voluntary and involuntary actions. Because once you swallow a bolus of food, like your chewed up hamburger, back to a certain point in your throat, your esophagus, you lose control of the ability, right? We all kind of recognize that. You can't bring it back up without coughing or throwing it up. So there's some voluntary. So vagus has a lot to do with voluntarily when you decide to swallow. But it also kind of helps with the involuntary. You'll get more of that in GI. And then it does somatic motor voice production. Those are its somatic motor functions. Autonomic motor functions is where we really say everything gets vagus input. Right, read through them. Smooth muscle contraction, relaxation of the GI tract, slowing of the heart rate, secretion of digestive fluids. There is so much more that go into, when we say dealing with the GI tract or the heart or digestive fluids, there's a lot more that we can talk about with them. And we will in special senses. But for now, it has sensory functions, it has somatic motor functions, and then some autonomic functions. Cranial nerve 11 used to be called spinal accessory because it actually comes off of both the brainstem and the spinal cord, but they simplified it down, stopped talking about that little Cliff Clavin knowledge, and just call it accessory now. If you don't know who Cliff Clavin is, actually, if you do know who Cliff Clavin is, and you've been too tight of a PA school, Norma's died. Cheers. Nobody. Somebody can talk to me about it. Somebody knows. And it originates from the brainstem and spinal cord. When you look at the accessory nerve, it's what's going to help with voluntary muscles used in swallowing also. But all we ever remember most of the time about cranial nerve 11 is that it innervates sternocleidomastoid and your trapezius muscles. So that's the main thing we always see. And that would be a somatic motor function because those are skeletal muscles. So it's innervating the pharynx and larynx and then shoulder movement. Well, that's what allows you to know. I don't know. That's what I answer to most of my wife's questions. I don't know. Reason? Because her questions don't really, not all of them. I'm not putting her down. I tell her this all the time. She'll say, you always say, I don't know. I'm like, because you're right. I wonder what the neighbor's dog was doing out down the road. I don't know. Meaning, I don't really care. As you get older, we lose neurons. I cannot take in all this additional information that I don't need. I'm trying to digress for just a second because we're getting into the last one. But I'm going to say, it sounds negative, but I don't need the additional details. If people take this as rude, if you ask me, you call me up and say, Mr. Wright, don't do this. Hey, will you stop at the gas station on the way into class and pick me up some chocolate milk? Sure, yeah, I'll do that. Because I got to go to the thing first. I don't need to know that part. You just stop when somebody says yes. Will you do this? Yes. Because don't go into why you need it done. They already said yes. I don't need to know that. If I want to know that, I'll go, no, why? Why do you need me to get your chocolate milk? I'll probably just say, yeah, if you're buying it, because I'm getting one too. Accessory, most of what you remember about that is sternocleidomastoid trapezius. Test that by having somebody, you can either have them shrug their shoulders, or if you ever seen them, you can have them, you place your hand and tell them to turn their head. Now remember, when you're doing physical exam stuff, we're not here to, you can overpower most people, right? You don't need to push their whole thing. Keep going, keep going. No, you just want to see if they can turn their head or no. I see it all the time. I see people doing their shoulders, and they're sitting, the patient's sitting, they really can't shrug really well because they can't throw and they're like pushing down, and you don't have to do that. Same thing when you see people do like empty can tests. They're supposed to be out here kind of, they're, keep it up.
We're already assessing.
Yeah. That's true with everything. I was thinking, he said when you're looking at all the functions that 10 does, you're assessing for a lot of that. And you can't see autonomic functions. That's the problem with autonomic, like reflexes. We really can't test them. We can test pupillary response, and that's about it that's clinically relevant. When we get to reflexes, that'll make more sense. But you made me think, when you've got a patient in front of you, especially right as you walk in the door, you're constantly assessing them. You are judging them 100%. And I'm judging you when you walk into my room or I walk into the room, I'm looking at, like, within the first 1 to 5 minutes, I'm deciding sick or not sick. That's the way I play the game. Sick or not sick. Meaning, do I need to do something in the next 5 minutes to save this person's life or change it? Or do I got all day? If you're not sick, I'm not going to take all day, but I have all day. It's an attitude. It's more of an ER attitude or a deployment attitude. Somebody comes in, they look terrible. Are they sick or not sick? Are they going to die on me in the next 5 minutes? Or do I have time to go Google this because I didn't learn that in kids? No. I taught a whole lecture on that once about identifying quickly sick or not sick, but you are constantly doing that for the cranial nerve. Then you run through them. Most people do a cranial nerve exam, and you are going to spend a lot of time doing it here. You're doing it about 10 seconds. Yeah, I'll have them done, boom, 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 it's done. Because they don't expect to find anything. And then some people note they did it and they didn't. We talked about that earlier. It's one of the things I see on charts. Cranial nerves grossly intact. Never did a cranial nerve exam. But maybe it was you and you just observed them all and I didn't know that. Come on, I brought you back into that to be funny. I wasn't saying, what do you mean you would do that? Okay, last one, hypoglossal. Guess what it has to deal with? Guess what the muscles that it's innervating are? They're under the tongue, so it's hypoglossal. So it innervates all of the extrinsic muscles and intrinsic muscles except one. So the exception is palatoglossus. And so all of your tongue muscles are used in speech and swallowing. So easier there just to learn the one muscle. So I'm not going to give you the rest of them because we're not nutritionists or anything. You'll never need to know all the muscles of the tongue, probably. But palatoglossus is the exception if you're looking into that. And because people always ask, palatoglossus is actually innervated by cranial nerve 10. It goes back to, I'm this way too. You're giving me an exception. You said all of the muscles under the tongue are innervated by cranial nerve 12, hypoglossal, except palatoglossus, and you left it at that. What's it innervated by? Cranial nerve 10. Vagus is like acetylcholine. If somebody's asking you a cranial nerve question, and you absolutely don't know, vagus is a safe answer. It is. especially if it's an autonomic system question. There's your hypoglossal nerve. We can have them stick out their tongue as an assessment of the hypoglossal nerve because that's the tongue muscles. I'm going to describe to you something you'll see later in physical exam. One of the tongue, well, there's pairs of tongue muscles. A group of two of them are named genioglossus muscles. And they're responsible for pushing your tongue out, protruding your tongue. And so like he's doing, I'm not going to stick my tongue out. You push your tongue out. But what if you push your tongue out, you ask somebody to stick their tongue out, and it goes to the side? The problem is on the side that it went to. So if the tongue points to the left, my left genioglossus muscle probably has a problem. The reason for that is, think about it, when muscles contract and pull, we kind of understand that. Like my sternocleidomastoid contracts, I'm coming this way. But we're pushing out. And so if this muscle is not working and this one pushes out, it's going to push it over. Guarantee you, when you get into physical exam, that'll be a question. Because they can make that confusing, right? So genioglossus is going to point towards the side of the defect. Always points at where the problem is. Oh my goodness, we reached the end of cranial nerves. Seems like it went by fast. What questions do you have? How do you feel about them? Good, bad, indifferent? You just feel like you got to get home and study them? Spend time on cranial nerves because it's going to pay off for your future. I mean, I mean it so much that if you were to walk in here and say, hey, they're going to give me a pass. What do they call it when you get credit? You know when you go to college, you have like pre-AP classes or AP classes that give you credit for that class? If you were going to walk in here and you walked up to me and said, Mr. Wright, they gave me AP credit for the freshman semester of A&P, and I'm going straight to the sophomore semester, what's the one thing that you could give me that'll help me? And I would say, cranial nerves. That's how important they are. You will not get away from here on out. You will not get away from cranial nerves. It's going to keep getting tied back in. The reason for that is a lot of the functions of the cranial nerves we see affect bodily functions. And so we're going to test those to see if you have other indicative of problems medically. So they're very important. So if you leave here and only know cranial nerves out of my class, I'm fine with that. But you're not going to. All right. We're a little bit early, but I got a video for you. I saw somebody had it pulled up back there. It's a commonly used way. Now I can tell you to start.
When you say let's go to breakfast, you mean let's go to McDonald's.
No, I don't.
Mixing.
Hi, welcome to Biomed Sessions with me,
He
Ruth.
says a few
Today we're
things
going to be
different,
learning the
but
functions of the cranial nerves. Cranial nerves are nerves arising from the brain, including brainstem. They are best seen from an inferior view, i.e. the underside of the brain, and there are 12 pairs of them in total, numbered according to where each emerges. A good way of learning cranial nerve functions is by copying out and memorizing this picture, which is basically just a head with shoulders, composed of the numbers of all 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 pairs of cranial nerves. Learn this and you'll have a pretty good idea of what each pair does. We'll go through it together. Cranial nerve 1 is the olfactory nerve. It is sensory, therefore relays information back to the brain. In this case, this will be in relation to olfaction, which is basically just your sense of smell. Handy, because the number 1 is the nose in the diagram. Cranial nerve 2, also sensory, is the optic nerve and is involved in vision. Number 3 is the oculomotor nerve. It is mainly motor, hence relays information from the brain to effectors such as muscle. Alongside cranial nerves 4 and 6, the oculomotor nerve is involved in eye movements. It is in fact related to so many eye movements that it would be best to learn which eye movements it is not involved in. If isolated, it cannot help move the eye down and out. This is the job of cranial nerve 4, and it does not help abduct the eye. This is the job of cranial nerve 6. The oculomotor nerve also has autonomic functions, i.e. those that are involuntary/unconscious. These include eyelid elevation, pupil constriction, and changes in the shape of the lens in order to focus on objects. This is known as lens accommodation. Cranial nerve 4 is the trochlear nerve. As mentioned previously, it is involved in moving the eye down and out. This actually occurs through a combination of depression, abduction, and inward rotation of the eye. Cranial nerve 5, the trigeminal nerve, is mixed, carrying both sensory and motor fibers. Tri means 3, which hints at the fact that this nerve has 3 branches which together aid in facial and teeth sensation, in addition to sensation from the front and middle thirds of the tongue, or more officially, the anterior 2/3. Also, it has motor fibers which are involved in mastication, i.e. biting and chewing. As we know, the abducens nerve, cranial nerve 6, the last of the 3 nerves involved in eye movement, abducts the eye. Abducens, abduction. Cranial nerve 7 is the facial nerve. It has motor fibers for facial expression and sensory fibers which are involved in taste from the anterior 2/3 of the tongue, not to be confused with the trigeminal nerve, which aids in general sensation to this same region. A good way of remembering the facial nerve's function is to imagine your facial expression as you taste your favourite piece of food. Additionally, the facial nerve is involved in saliva and tear secretion. The vestibulocochlear nerve, cranial nerve 8, is a sensory nerve which gets its name from the structures in the inner ear which it innervates, the cochlea, which is involved in hearing, and the vestibule, which is involved in balance. Hence, the vestibulocochlear nerve aids in these functions. The glossopharyngeal nerve, cranial nerve 9, also has an interesting name. Glossa means tongue, and pharynx is the back part of the throat. Hence, it's no surprise that it carries sensory fibers for taste and sensation from the posterior third, i.e. the back part of the tongue, and has motor fibers that aid in swallowing. It is also involved in saliva secretion. Cranial nerve 10 is the vagus nerve. Now, although I drew it really small on this diagram, the vagus nerve is actually a huge nerve which is mixed and extends further than all of the cranial nerve, which is why it is referred to as the wandering nerve. Indeed, it wanders about and supplies a wide range of structures. On the sensory side, it carries sensation from the pharynx, larynx, thorax, abdomen, etc. It is also involved in taste using a flap of tissue at the back of the throat known as the epiglottis. It has motor fibers which aid in swallowing and speech, and autonomic functions such as decreasing heart rate, gastrointestinal tract contractions to aid in moving along food, and sweating. You'll be relieved to know that our next nerve, cranial nerve 11, is much simpler in terms of function. The accessory nerve carries motor fibers which help you shrug your shoulders and turn/tilt your head. And finally, cranial nerve 12 is a hypoglossal nerve, which is purely motor. If you remember, glossa means tongue, and hypo actually means under. Hence, this is a nerve that is found at the undersurface of the tongue and aids in tongue movements. Okay, that's our 12 pairs of cranial nerves done. If you found this tutorial helpful, give it a thumbs up. And if you want to see more videos like this, then do subscribe. Okay, see you in another video.
I never do thumbs up. Does anybody ever do that when they tell you to? Subscribe. All right, thanks for the video. What's the sensation function of cranial nerve 12? She didn't mention it. Just finishing up. Proprioception. Remember, if we don't mention it, it's proprioception. That's it. That's the cranial nerves. That's where we stop for today. Tomorrow we pick up the spinal cord. If you have a really hard time with cranial nerves, come and see me. Let's get on that. Or find somebody who is good with them. There are people in this room, many people in this room, I'm sure, that know cranial nerves fairly well. There's some intricate things that when you're out there practicing clinically that you don't remember, but in general, they know the cranial nerves, and it's very easy for them to pick back up on them, and they may be able to say it a different way than I did that helps you get it. Right? So don't go try to kill yourself on learning cranial nerves if you're not getting it. Ask somebody else to help explain it. There's a lot of ways that people use to remember them. I'm only giving you some ways. If you got to start with knowing military time, cranial nerve 8, vestibulocochlear, 1400, 2 p.m. You should be able to interchangeably do that. Why do I keep saying that? Because around the schoolhouse, we think, oh, I'll remember that. But if you don't learn them to snap like that, what do we do when we test you around here in every test? They put a timer on it. When that timer's going, it's a little hard to remember that stuff that you haven't committed to memory that way. And I know that knowing the name of the cranial nerve and its number will help you get to that, right? If you know the name and number, you have a chance at figuring out what it does. because it's named for what it does. Hopefully, as always, like I say, that makes sense to you. So figure that out, learn that way, because even I and other people, most people will write a question, even on the pants, if we talk about cranial, this person has a, they wouldn't say it this way, but this person has a cranial nerve 4 problem. And you're like, well, wait, the books always give you cranial nerve 4 trochlear. It ain't going to happen that way. It's just not. I'm not saying just for me, I'm saying all the way up. They're going to assume that you know what cranial nerve 4 is. You know the name of cranial nerve 4. We don't need to say it again. Yeah. Hopefully, I'm giving some people some good stuff. Other people are like, well, you shut up, quit talking. And I'm fine with either one. Y'all have a good day.